sharing your wealth of knowledge with us, and I'll let you get going.
Thank you so much for having me. I'm a newbie to Project Echo Geriatrics, and this format is so brief. We'll see what I can do. I'm going to go fast. I apologize in advance. I'm here today to talk about dementia prevention, which by the end of the talk, I think you might agree that from a clinical care perspective is really just that these days, at least, the promotion of healthy brain aging. The question, can we prevent dementia? The answer is no, okay? There's no cure, no good therapeutics even. Frankly, we still don't understand exactly how people get it or why some people don't. The current thinking is concepts of reserve and resilience for why dementia may not occur, this combined with risk factors. So when we think about reserve, in these situations, it's an individual who actually has pathology in the brain, some sort of neurodegeneration is taking place. However, there is something else going on that basically gives them the strength or ability or cognitive reserve to keep functioning at a high level despite that accumulation. In cases of resilience, there are likely some sort of protective factors, either from early life experiences, genetics, who knows exactly. And then in addition, these are individuals who have not had things that increase their risk, right? They were never smokers, never abused alcohol, things like that. So what are the top risk factors if we want to think outside of reserve and resilience? Everyone has risk factors, right, for developing dementia. Some of us have higher and some of us have lower risk. Anything that could increase one's risk of developing a condition would count. And I always want to emphasize, just because you have a risk factor or your patient has a risk factor does not necessarily mean they will develop the condition. This is a double-edged sword when we work with our patients, because someone can work really hard to manage their risk factors and reduce them, and it doesn't necessarily mean they will avoid the condition. So age is a top risk factor for dementia, and obviously we would like to continue to age and do so healthfully. Unfortunately, over age 65, the risk of developing Alzheimer's or, say, vascular dementia, the two most common in aging, doubles every 5 years. There are genetic risk factors. We are not talking today about the familial types, the genetic mutation types of Alzheimer's disease. Those represent less than 5% of cases. I'm talking about your run-of-the-mill sporadic Alzheimer's and other types of neurodegenerative diseases. So there is one risk factor that's known, having an apolipoprotein 4 allele. We all have 2 copies, but having one of those be the 4 allele is an increased risk, but there's really nothing we can do about that, right? So let's focus on modifiable risk factors. The Lancet Commission recently put out an update to their 2017 report on dementia prevention, intervention, and care. I'm going to take just a quick moment here running over those that fall into this potentially modifiable category, which is 40%. In early life, less education increases risk. So think about the flip side of that. More education is potentially protective, and we know that that's definitely something that contributes to reserve. So in this particular article, they really highlighted how it should be a worldwide public health emphasis to increase education for children. In midlife, protect your hearing. 8% is attributed to hearing loss. This is actually the least understood category, but it does seem to hold true across many studies. Let's see, next up, traumatic brain injury. They have this in modifiable. I work with older adults, so I don't usually think of it as modifiable, but it is in early and midlife, right? Wear helmets. Don't engage, if possible, in high-risk activities. And frankly, this is a negative for contact sports. And of course, I work with veterans, so I deal with lots of individuals who've experienced blast exposures. The last 3 are really pretty darn modifiable: hypertension, alcohol, and obesity. Exercise being, again, I like to always flip things into a proactive, protective kind of manner. Think about how exercise can really, really help with those. Moving on to later life, smoking, entirely preventable, right? Except for that nasty little addiction piece when it comes to nicotine. So it is always important, any opportunity we have, if we have someone who is currently using tobacco or smoking really anything, to work with them and not just drop the idea of them quitting smoking. Let's see. So there's also depression, social isolation, physical inactivity, air pollution, and diabetes on this list. All of these are modifiable. All of these can be flipped into a positive, proactive treatment plan and behavioral modification. Air pollution, actually, I should say, is probably often out of an individual's locus of control due to employment, SES factors, things like that. What didn't make this list that I think you'll be hearing more and more about is sleep. That's the topic on the horizon. Insomnia, untreated sleep apnea, these are worth attacking. There are so many emerging studies of glymphatics that strongly suggest that as our sleep cycles decay with increasing age, that is a clear mechanism by which our brain fails then to clear toxic and miscleaved proteins. And also remember, sleep meds are not a fix in this area. Those actually don't do anything to improve the critical sleep stages for brain reparation or for memory formation. So we're left with that 60% risk unknown. It's not really risk unknown. That's the genetics. That's the unavoidable factors like increasing age. Okay, I am not going to read these slides to you all. This audience is probably pretty familiar with hypertension and other facets of vascular disease. I think the important thing is, what can you do? You know, in addition to trying to work to control the appropriate aspects of blood pressure and cholesterol, you want to think about vitamin B deficiency, hypothyroidism, iodine deficiency, and of course, smoking. Very bad. There are less certain things that could potentially help here. Better sleep duration has been linked to improvements in this area, reducing obesity, especially central obesity, decreasing carb and saturated fat intake. So there's that dietary nutritional attack as well. Smoking, I am not going to read this. We all know smoking's bad, and it's so hard for those that are still using tobacco, but just sometimes people don't appreciate how much it increases the risk of dementia. And encouraging folks by the literature, which suggests that smoking cessation can actually, within a certain time frame, decrease one's risk almost back to that of never smokers. So that's why it's so important. There are some groups in which the smoking probably connotes an even greater risk. Those who are ApoE4 negative, who are less likely to develop dementia. If they're smoking, they've just probably, essentially given themselves that risk factor. Okay. Obesity. Oh gosh, there's a lot here. I think it's just really safe to say that there are tons of models showing that obesity with insulin resistance and impaired glucose metabolism essentially accelerates the aging of the brain. The flip side of that being that if you can have really great glycemic control and really great insulin sensitivity and no obesity, it's associated with many factors that lead to longevity. Diabetes, of course, obesity, and as well as genetic predisposition and other things can lead one to develop diabetes. This is also a treatable condition. I'm speaking of diabetes type 2 here, although both diabetes type 1 and type 2 are known to be associated with cognitive impairments. So here's some of the underlying mechanisms. I'm going to share my slides, by the way, as a PDF after this for anybody who's interested. And this leads to various types of brain pathology, not just Alzheimer's disease, not just vascular, although it does seem to lead to these and independent mechanisms, and just sort of this overall brain aging. So I'm a psychologist, a clinical psychologist by training, and of course I'm concerned with what mental health conditions might increase risk. Depression came out in that Lancet Commission review as being a risk factor. It is interesting to note that it does seem that treating depression can actually decrease the risk. Also, be on the lookout for folks who are developing depression or worsening depression with increasing age. Sometimes those depressive symptoms are actually a feature of the onset, a prodromal stage of dementia and or some of the first symptoms presentation, particularly in vascular dementia cases. PTSD is of special interest to me as someone who works clinically with veterans. There are a number of studies which suggest that those with chronic PTSD are doubled in their risk for dementia. There is some back and forth on this. These are obviously, they're very, very large studies and strong in that way, but they are associative studies. Anxiety actually has not been shown to have as much association with risk of dementia, although there are other research studies that suggest that certain personality types, if you think about personality dimensions, which do tend to have more anxiety, may be associated with greater risk. Basically, happier people are at lower risk. Physical activity, this is just this article that showed this J-shaped relation with mortality risk with greater versus less physical activity. It's mortality, not dementia, but that actually is echoed in the dementia literature. The reason I wanted to keep this slide from the longer version of this talk is that the physical activity guidelines are recommending a very high level of exercise, right? 75 vigorous or 150 moderate minutes of exercise weekly. When we have older adults go walking, they are not getting exercise at that level. So keep that in mind. Sorry, I guess I have a little animation here. Let's get rid of that. This is the association of reduced risk for dementia in those that have higher levels of physical activity. However, the challenge is that when there have been randomized control trials of aerobic exercise in those 55 plus, they are not finding that aerobic exercise or generally increased fitness improves cognitive function in these individuals. There's so many reasons though why these studies may not be showing the effects of these other large cohort studies. Some of it is that almost none of these studies have people actually doing exercise at the level that would meet physical activity guidelines. They are often working with folks, they don't know it, but who are prodromal dementia. And their methods of measuring cognition are often incredibly blunt, using insensitive instruments like the MMSE or things like that. So I don't want to throw the baby out with the bathwater when we look at these RCTs. Alcohol use, light to moderate alcohol use has been associated, by the way, this wasn't in that list for the Lancet, was it? Because we want to be careful promoting alcohol use. But those who have light to moderate drinking do seem to be at a slightly lower risk of developing dementia or cognitive impairment. I cannot help though but follow up with some caveats here. Alcohol can be a primary or secondary cause of dementia, either through, say, a Wernicke-Korsakoff or alcohol-related syndrome, or even just for its increased risk if drinking more than recommended amounts for developing Alzheimer's or vascular dementia. It, of course, increases risk of stroke and heart disease. Those are not good in aging. And I think critically, we have to remember that older adults are not immune from alcohol dependency and abuse disorders. You see here some of the numbers for at-risk drinking. I think the interaction of alcohol and the numerous medications many older patients are on is also critical. So you can imagine, and it's well known, that it increases the risk of many other potential geriatric syndromes: falls, head injury, delirium. And a lot of folks over 65 have no awareness, and it's kind of understandable, but it's our job as healthcare providers to help them find this information on what are the recommended drinking limits for older adults. And I'm emphasizing those without cognitive impairment. And here they are. They're brutal, especially if you're an older woman. You do not get to drink much, is basically what it comes down to. And you certainly can't drink what you did in your 20s or 30s. So working with our patients, I really think it's so important to every time we can, every time possible, to try to flip that perspective towards positivity in aging rather than the negative effects of aging. We want to be able to respond to our patients in a positive manner. This does not mean that we have to keep up with every latest news flash or fad, because holy cow, they are all out there. If I had more time, I would have done my Google search of recent news articles on dementia risk and shown you how hilarious for us, but not for our patients, this information is. It'll be things like flies hold the answer to the cause of dementia. Don't bother trying to eat healthy. It won't help you with dementia. New herb extract will be a future treatment. There's all sorts of crazy things out there. And so I threw out some of the things that are not so crazy, which often do have some literature behind them, but which often are not where folks should be putting their energy. things. Okay, I got to keep going here. So in terms of tips for talking with your patients, I think my number one recommendation is just to try to be composed. And that's really hard for me, at least. Maybe you all are better poker faces. But if I have someone come in and tell me that they want to avoid Alzheimer's disease because their mom got it in her 80s, and they're, by the way, only 60, and so they've started putting 3 tablespoonfuls of coconut oil into their coffee every day, and they've increased their coffee consumption and they're having it at night, I try to not have a strong negative response. I have to try to keep up with the literature. I can only do so much when it comes to the popular press. And I think when I'm trying to provide education, it's always better to show, not just tell. And it doesn't have to be that you have like 1,000 research studies at your hand and graphics, but just taking a pad of paper and drawing out sort of that inverted U or J-shaped curve to explain why maybe a little coconut oil might not be bad, but here you are up here in the deleterious range, etc. Folks don't often know where to find reputable information. So at the very least, be able to direct them towards some good websites, either government websites or, not to promote private websites, but Mayo Clinic often has a lot of great literature. I also recommend for folks that if they read anything about like a supplement or a brain scan that will really, really achieve big, big gains for big money, that's the time to get suspicious. And then somehow, as we do this, we have to try to keep hope alive for individuals. And that's a really challenging tightrope to walk. So I've got a couple different, I'm chairing a healthy aging and cognition education national work group for the VA. And we've developed a number of different materials. If my little video screen is still showing, you'll see we have pocket cards, we have little booklets. I helped create this RX for healthy brain aging, which was meant to be sort of like almost like a prescription pad checklist that you could go through which of these you think might help your patient more, check them off, talk to them about it. But I'm going to challenge my own RX list here. We're currently redeveloping this to make it more patient-centric. We want to engage our patients in a discussion of what matters to them, what is of value to them, and then use motivational interviewing, which is just a really simple psychological skill that's easy to learn and apply, to help them tell us what matters and help them identify the steps that they can use and take to get there. So for example, a veteran recently told me that I diagnosed him with mild cognitive impairment, and his goal is that he'd like to see his granddaughter graduate from college. She'd be the first in our family, right? This is a big deal. So what did we do? We went down this list and decided what were the big heavy hitters? What was the low-hanging fruit for him that might help him get there? All right, that's the end of my